Hello, everyone. Thank you for engaging in our IPCP live seminar. We will also be recording this for those that weren't able to make it to interact with at a later time. At this time, I would like to just put on the record that we have obtained verbal consent from everybody that will be in this video to have it be posted later so that when it is on YouTube and then you all have the link to it, there won't be any issues with that there. We would like to just thank you for coming into our seminar, and we want to just go through a couple ground rules throughout the meeting. If at any point there are any questions, please reach out to our faculty email at ipcpacademy@gmail.com, and we would be happy to answer any and all questions that you have. Without further ado, I'd like to go through some introductions of our faculty. I'll start with myself. My name is Benjamin Coletti. I am a second-year doctorate student in the Doctor of Athletic Training program at Indiana State University. I currently work as an athletic trainer in rural Indiana in the secondary school setting.
My name is Dan Waterman. I am also a certified athletic trainer in the state of Maine, and I work in an interprofessional office with chiropractors and massage therapists.
And I'm Shannon Wright. I'm also a student in ISU's Doctorate in Athletic Training program, and I'm also a certified athletic trainer, and I work in the state of Iowa at a recreation services in the university setting.
And I am Justin Young. Like the three fine individuals before me, I'm also an athletic trainer and a member of the 2021 cohort Doctor in Athletic Training program at Indiana State University. I currently practice in rural Indiana as well with public safety patient population.
Awesome. So at this time now, we are going to begin our presentation. Okay. Perfect. So let's go ahead and
So the purpose of this course is to discuss the foundations for interprofessional and collaborative practice. So to do that, we're going to touch on three primary areas. The first is going to be foundational knowledge of the terminology used to describe interprofessional and collaborative practice. The second is to build knowledge about why IPCP is important in healthcare. And the third is to talk about strategies surrounding shared decision-making and communication.
So before we get started with some definitions, we kind of have to expand on the understanding of where has interprofessional collaboration come from. And so in 2000, the Institute of Medicine, which is now the National Academy of Medicine, came out with a recommendation for all healthcare providers to establish a standard for practice for patient care. And so they came up with both a strategy and core competencies. And so the core competencies include things like evidence-based practice, patient-centered care, healthcare informatics and technology, quality improvement, and then finally interprofessional collaborative practice. And what we'll start to see and start to develop through this presentation is that that's really developed over the last 20 years. But in order for us to be able to really elaborate on a lot of those changes, we need to understand some of the definitions and the terminology that we're going to be using. And so the way that I look at them is in really three different kind of domains, and so or three different pillars, we'll say. And so the first one is the unis. And so what this means is that we have uniprofessional education and uniprofessional practice. And so this is these are professions that only learn or areas where only one profession is present. So when we think about uniprofessional education, we think about like nursing 101 or athletic training 101, where there is a group of students that are all a part of the same profession being taught by their own profession. As well as uniprofessional practice, we often think of like a dental office where you have a dentist that is the sole provider there, or even some primary care facilities are that way as well. And so that is kind of that uniprofessional practice. The next one is multi-professional practice education and and parallel learning. So in this system, you have people learning and practicing side by side, but not necessarily collaborating. So in the educational side of it, think more of like your gen meds, the anatomy and physiology, the biologies, those kinds of things where you have a lot of different healthcare professions all learning together, but not really collaborating on patient care. And then we also see that very often. This is what we typically saw in American healthcare, especially back from the 50s all the way up until the mid 2000s, where you have a lot of different professions in one area, but not really collaborating with each other, seeing each other as kind of individualistic practices. And so finally, what the Institute of Medicine, the National Academy of Medicine, the IHI, a lot of the American Medical Association has really been pushing for the last 20 years is a transdisciplinary approach, where we have interprofessional practice and interprofessional education to create this approach of patient-centeredness that helps share the workload among multiple professions. And so each profession has its own unique knowledge, its own unique approach on patient care. And so what a transdisciplinary approach does is it creates this shared decision-making with the patient to really again transcend that individual type patient care to make sure everybody is on the same page. So so why are we defining these? So there is an expansion on interprofessional practice over the last 20 years since the Institute of Medicine's Quality Chasm paper. And so some important dates to remember is 2008, there is something called the triple aim, which we're going to watch a video of later. And then in 2014, that's expanded on. So we're going to watch a short video that explains the triple aim a lot better than I can. So we'll watch that now.
The triple aim was the brainchild of two of our faculty, John Whittington and Tom Nolan, who came up with it in about 2006. I remember them coming in with the idea. And it was a real breakthrough. So the goal they had in mind was to articulate in a very efficient way the aims of healthcare. Up until that time, the answer would have been probably the best answer would have been reference to the Institute of Medicine report, Crossing the Quality Chasm, which had laid out 6 dimensions of quality, 6 dimensions of need. They call them aims for improvement. And those, most people in the field now know them. They're safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity. Everyone up until that point would have said, well, that's what the social need is, the 6 aims. And Whittington and Nolan said, no, wait a minute. That's about if you need the care. So if you need the care, absolutely. It's those properties should be there when you care for your heart attack, your broken arm, your depression, or you get your checkup. In the individual experience of care. But they said there's actually a second component of aim, and they call that the health of the population. Because why do you have your heart attack? Why did you break your arm? Why are you depressed? And the causes, they don't lie in healthcare. The cause of illness isn't the absence of healthcare. Healthcare is a repair shop. So they said that society also needs us to help you stay healthy. And the third aim they added, which I think was particularly brilliant, is while reducing per capita cost. And that is because the needs of the society, the people we serve, go beyond healthcare. They've got other things to do with their resources. They may want to go to the movies tonight, or a corporation maybe want to be more competitive and pay its workers more, and government may need to put money into roads or schools. So they posited this collection, this system of aims: better care for individuals, better health for populations, and lower per capita cost as is a complete statement as they possibly could of the social need we're here to fill. It's like a compass direction that tells us what success is. And that became known as the triple aim.
So the triple aim, again, he uses a really good analogy. It's a compass of the direction that healthcare wants to go, and it sounds great, right? So improving public health, improving societal health to reduce overall per capita costs and improve patient experience. So the triple aim was something that was written as a white paper in 2008. So what this did is as healthcare systems adopted the triple aim, what it did is it now expanded the role of the physician and the healthcare system in general, the healthcare providers. And so what happened is instead of policy being made for people who are sick in the healthcare to go to the healthcare system, now that role kind of shifted to where we're still taking care of sick people, but the expectation is that they don't get sick in the first place. And so this really rose the expectation of the healthcare providers by the public, while increasing the demand because the population is growing as well. And so we're increasing the role of healthcare providers while also increasing the demands from the public. And then as healthcare informatics continues to develop, and as insurance companies continue to demand reimbursement paperwork and clinical reasoning as to why they're paying for services, what this does is it creates a negative effect for the healthcare providers. So Ben, go ahead. So what this means is it's all good for the patient. It increases time spent with the patient. It increases the number of appointments. It increases the number of preventative screenings. However, it also increases the stress level on the healthcare providers. So we have increased paperwork. We have learning new systems. The need to see more patients in order to increase revenue, because insurance companies are continually denying poor reported outcomes or poor reported reasoning. And so what this essentially did from 2008 till about 2014 is it created a lot of burnout among healthcare providers. And so we saw this mass flux of primary care physicians, general medical practitioners, athletic trainers, physical therapists. We saw this big shift of people getting burnt out and leaving their professions. So in 2014, there was another white paper written by Bodenheimer et al. That added in a fourth aim. Now, it's unclear to me whether or not the IHI has truly enveloped the fourth aim or not, but it's certainly something that a lot of healthcare systems have adopted, in which is to take care of the providers, is to add the healthcare team as part of the patient experience, and make sure the healthcare team is a part of the patient experience as well. And so the fourth aim really talks about taking care of the healthcare team by sharing a space. So it increases that intercollaborative practice, shared document systems, so that healthcare providers aren't doing their own individual notes. They can go back and look at other people, so they don't have to go through a full subjective history or objective history. They can kind of expand upon previous knowledge. Expanding roles within the healthcare team. So trying to help people or help practitioners really practice at the top of their license, and just generally improving interdisciplinary collaboration. And finally, the biggest component of this is shared decision-making with the patient. And so having multiple professions intercollaborate to create an environment where everybody feels valued and reduces the hierarchy of that healthcare system, so that everybody's opinions can be heard and the clinical reason behind those decisions, and then making those decisions with the patient. So around the same time, the World Health Organization also had, in 2010, developed some interprofessional collaborative practice and interprofessional education as well. So Dr. I'm going to say this wrong, Ransamy, who was the president of the World Health Organization in 2010, who also had the title of the Minister of Medicine, which is the best title ever. So she recognized that this is something that the World Health Organization has identified since 1978 to be an issue, and a lot of their studies showed is that it wasn't just a language barrier between healthcare providers providing care to underserved populations and responding to emergent events, but it really was this hierarchy of the world saw the healthcare system as a hierarchy. And so that then filtered into the healthcare professions and really was detrimental to care. And so what Dr. Ransamy did is she developed two committees that then became one through the World Health Organization, which was an Interprofessional Education Committee and an Interprofessional Collaborative Practice Committee. So going from that multidisciplinary approach to a transdisciplinary approach through the World Health Organization, which is something that really pushed not just the world paradigm, it shifted the paradigm of the value system in healthcare through the world, but also it pushed the American healthcare system to go towards that value-based healthcare system. The Interprofessional Collaborative Practice Committee through the World Health Organization really targeted 4 very specific domains that they feel all healthcare providers should be doing in order to create a healthy collaborative environment. And so these are those 4.
So the first domain is values and ethics for interprofessional practice. And what that domain states is work with individuals of other professions to maintain a climate of mutual respect and shared values. So at this point, we'd like to take a moment. We have 3 questions for reflection. We're going to put all 3 questions on the screen now. I'll go ahead and read them. The first question is relative to your clinical values, and these are going to be crucial when identifying the values of others that you would like to work with. So first question that we would like you to reflect on is, what are your clinical values? The second question is, who do you currently collaborate with? And then the third question is going to relate to both of the first 2 questions. What values do you see in that provider that you also value in your own clinical practice?
The next domain is roles and responsibilities. The definition of this is to use knowledge of your own role and roles and responsibilities and those of other professions to appropriately assess and address the healthcare needs of the patients that you serve and the populations that you serve. So some of the reasons this is really important are because you have to be ready to communicate your roles and responsibilities well to other professions so that they understand what you are doing with the patient if you're sharing patient care. One of the other aspects of this that is really important is listening when others tell you what their roles and responsibilities are. This helps ease that navigation of the healthcare system for you and the patient. Part of patient-centered care also includes being able to translate this information into a way that patients can understand. So going from medical terms when you are describing your roles and responsibilities to another healthcare provider to layman's terms when you are describing them to the patient. Another way this can help is being able to describe another healthcare provider's roles and responsibilities to the patient to help them make decisions in their care and understand what is going on there. So one of the other things that this really helps with is when you're making a call for a referral, knowing what other providers do and what their roles and responsibilities are can help make that referral process easier, especially if you work in a big healthcare system where you can make those types of referrals, and help smooth out that patient transfer because you understand what they need to know and what is relevant for them when you're making that call. And here we have the quick top 5 roles and responsibilities of a radiologic technologist. So this is a good activity where you can ask yourself, what are your top 5 roles and responsibilities? So this is a good thing. Keep in mind that what your particular job now is, as well as what your profession states it does, and what is important for the patient or provider to know in that moment. So if you're communicating with a new provider, what do they need to know about your role in your system now, and what, say, an athletic trainer does in general. Other things to keep in mind are when you're doing this, be concise and practice. So think of this as an elevator speech where you are doing a quick 30-second overview of what your profession does and what your job is and how you're helping the patient. So we're going to take a few minutes right now and practice writing down what your top 5 responsibilities are. And then you can use that to start sketching out your elevator speech on your own. And so, as we may or may not have all experienced, there are challenges with interprofessional care and practice, and challenges within the roles and responsibilities specifically. So one of the areas where this can really show up is infringement on areas of expertise. So individual healthcare providers feeling like their expertise is being infringed on because there are similar roles or responsibilities. And this leads straight into an overlap of roles. So this is where communication can be really important and helpful in understanding where the boundaries of one provider's roles end and the others start, especially when those roles are so similar or there's overlap. Kind of like Dan was talking about earlier, there are hierarchies in medicine, and this can impact communication, patient care, patient outcomes, and provider experience as well. And so that can be from a zoomed out perspective of the overall healthcare system. So in the US healthcare system, we place physicians at the top of our hierarchy and everyone else kind of falls underneath of them in varying levels. Or it can be really zoomed in a particular system where, say, it's a long-term care facility where certain providers have more status and more different, more important responsibilities than people who are providing actual care or those workers in the facility that are not healthcare providers. All of those things can lead to poor coordination, whether that's with the roles and responsibilities overlapping or with that hierarchy of where one provider doesn't necessarily want to speak to the power of the provider above them. And then that leads to a lack of communication, which just creates tension and challenge within the roles and responsibilities and interprofessional collaborative practice.
So in the third domain for interprofessional communication, we look at how providers will communicate with patients, families, communities, and other health professionals in a responsive and responsible manner that supports a team approach to the maintenance of health and the treatment of disease. So a lot of the times when we are talking about looking for new providers to interact in the area, or not necessarily knowing what providers may be in our area, we want to be able to come up with some type of way that would create that concise communication. So kind of building off of what Shannon had talked about in terms of sharing your roles and responsibilities, this domain 3 of communication is a really good way to talk about how you would have that first interaction with a provider. So we want you to think about what would be your phone call. What would be the phone call if you were to call a new provider and ask them potentially for advice on a case or look to collaborate on the case? Maybe you both had the patient at one point and you were asking about a certain result or a certain evaluation that they had and a certain note that they had taken. What types of things would you be looking to talk about? So the activity that we want to do at this time and take a few minutes would be to think about a complicated or unique patient case that you may have right now that you feel would benefit from having another provider involved. What would be 5 distinct points from that case that you feel are important that would need to be shared in a phone call to a provider so that they could help you? What are the 5 unique points that is making this something that would look for that referral? So we want you to take a few minutes now to think about those and think about what you would need from that other healthcare provider. So building off of that activity and moving into domain 4, we're going to talk about how your teams and the teamwork is actually going to happen. So in this domain, we'd like to apply the relationship building values and the principles of team dynamics to perform effectively in different team roles to plan and deliver a patient or population-centered care that is safe, timely, efficient, and effective and equitable. So with this activity, we want to build on the activity from domain 3, where we talked about how we would seek out the providers and what type of things that we would offer to them to help in our patient case. And in this activity, we want to spend the next take about a 5 to 10 minute break and have you search for providers in your area that you feel would have a beneficial collaborative role. So make a list of somewhere between 5 and 10 providers, whether that be in your network that you haven't had significant collaborative interaction with before, or in your area that you feel you could collaborate with in the future. Write down their name, their credentials, their profession, and some of their contact information. So we'll take a break now for you to begin that. Now that you have established a list of providers that you feel would provide a good collaborative environment for you to deliver better patient care, we want to talk about specifically a strategy and an activity that you can use when interacting with other providers, and that is a grand rounds activity. So in a grand rounds activity, providers gather to discuss a unique or difficult patient case that has some characteristics that the provider would like advice about. So this may include different providers and provide some benefits in education, engagement, diversity, and collaboration. Now, one thing to note, this does not necessarily have to be a group that brings in different providers. It can be providers within the same profession that just have different experiences. But the big thing about grand rounds is that it would be an opportunity to come together and have that collaborative experience. So specifically with education, grand rounds provides the opportunity for providers to learn more about each other. So like I said, it wouldn't necessarily need to be the case where if we take athletic training for an example, just because there are a group of 5 athletic trainers does not mean that you're not learning about a different provider, because there may be a certain skill that they have that you don't have that you feel that you could benefit from learning about through the grand rounds activity. And that would go for any other profession, just as well as you could have a group that is maybe mixed with a primary care physician and a physical therapist or a speech pathologist, that will all be able to learn a little bit more about those roles and responsibilities like we talked about before. In the engagement section of Grand Rounds, this allows people to invite others to share a voice and to give that voice to all providers and kind of talk about how we don't have to take the hierarchy that sometimes is established in medicine exactly to how it is laid out. So it allows the providers that traditionally had been seen lower in the hierarchy to have their voice with all providers in the same space. In terms of diversity, it allows for different perspectives to be brought about, whether that be just because the providers come from different areas, or if there are actual, especially when you're talking about social and behavioral factors that impact patient cases, it allows for a lot of information to be shared in a diverse and unique way. And finally, the collaborative aspect, which is one of the biggest aspects of the Grand Rounds activity. This allows for the sharing of ideas and helps providers deliver better patient care. It's kind of a culmination of all the factors that we've talked about before. And the Grand Rounds activity gives that opportunity for providers to be collaborative. Now, one of the things that we would like to talk about is that this is a little bit more advanced of a strategy. This is not something that you may be able to invite a provider to engage in right off the bat. So you may need to work through some of those other some of the other domains first that we talked about and some of the other activities that start that relationship. And so we'd like to summarize that now.
Our key take-home points at this point of the presentation are that this really takes time and effort, but small interactions can make big changes. So to review all the different strategies we discussed, well, the first one is just to reflect on the quadruple aim. So how can you get better outcomes for patients, lower their health care cost and burden, improve a patient's experience, and improve your experiences as well? And where does interprofessional collaborative practice fit into those 4 questions? Next, reflect on both your clinical values and also the values of your profession and the values of your employee and organization as well. And be able to identify those values in other providers that you're looking to work with. After that, understand your roles and responsibilities. Review your licensure, review your job description, and be aware of what you're being asked to do within your system or place of work. Once you understand that, practice your elevator speech and have a speech prepared for both other providers and patients that you might encounter. Research the roles and responsibilities of providers in your area. Review their state licensures so you know both yours and theirs. And then go have actual conversations with providers about how they view those roles and responsibilities and how they think they may be able to benefit your healthcare team. And then lastly, practice communication with strategies like Grand Rounds, as Ben just discussed. I think what's important to remember with all of these different interventions and strategies is that we're asking you to do them individually, but in the end, you have to engage with other providers for them to have benefit. So start small, start with these small strategies and practice with yourself, and then build towards communication with others. At this point, we would like to open up the floor for discussion. If you have any questions, please email the group at the link that Ben mentioned at the beginning of the presentation. That link will also be available, or that email will also be available in the description of the video. We're looking to have conversations. As much as we preached communication today, we'd love to communicate with you in different ways. So please reach out so we can continue this conversation and grow as providers and people. Thank you.
So as we close up the presentation here, again, thank you for interacting with our presentation. And I'd like to give you a few of the logistics that will happen as a result of registering for this seminar. Each person that has registered for the seminar will be sent a recording of the session, as well as a recording of an example Grand Rounds activity, as well as a flow sheet that can be used for the provider presenting a case during a Grand Rounds activity. We have one that is blank for you to use in the future, and we also have one that is filled out to give you examples of information from the patient case that can be talked about throughout, and how it's a little bit easier to formulate it so that the activity can run a little bit more smoothly. So again, that will all be sent out after this seminar, and will be allowed to be used by you to hopefully improve interprofessional collaborative practice in your setting. So thank you for joining us.